MSK anatomy and physiology, ankle sprains, signs of lumbosacral radiculopathy, and neurovascular pairing. All right, so this is kind of just like a miscellaneous stuff that I paired together at the end. So what I want you to know first off for ankle sprains is the anterior talofibular ligament is the most common ankle sprain overall. And the way that you can remember this is just always tears first. So always tears first, ATF. Now, don't get bogged down and remember only ATF and then pick whatever like ligament starts with A, T, and F, right? Because they could try to trick you and put another ligament that is A, T, and F. Just remember, anterior talofibular is going to always tear first, all right? That's all you really need to know about the ankle. Next is going to be signs of lumbosacral radiculopathy. So what happens is you're going to have like paresthesias and weakness related to specific areas that affect kind of like in a spinal nerve distribution on your body, okay? And so that's going to be a sign of lumbosacral radiculopathy. And all that it is going to be a displacement of the nucleus pulposus, all right? So it's essentially kind of a bulging of the nucleus pulposus, and that's what's going to cause the signs and symptoms of the lumbar sacral radiculopathy, all right? Now, and what that is just a disc. It's a vertebral disc. That's what's bulging, all right? So that's what's herniating out. And so it's going to herniate posterior laterally, and what you kind of need to know, main takeaway, is that which nerves affect what type of symptoms. So first off, if you have like L3, L4 disc level herniation, so that means the nerve root that's affected is going to be L4, okay? And so the dermatome that's affected obviously is going to be the L4 dermatome. And since you know that 3, 4 kick the door, that's our patellar reflex, well, since L4 is affected, you're going to have a decrease in patellar reflex, okay? Next is going to be our L4, L5 disc level herniation. So L5 nerve rootlet is affected. And so that's going to cause weakness of dorsiflexion, okay? And it's going to lead to difficulty in heel walking because it's peroneal nerve damage, right? We talked about peroneal nerve back in the previous chapter, and that's L4 to S2. Specifically, L5 is the main key thing there. So you have difficulty in heel walking, okay? So that's known as drop foot or foot drop, right? And then lastly, you have S1, so disc level L5 to S1, and S1 is the nerve root that's affected. You're going to have difficulty in toe walking because that's going to hit the tibial nerve, but you also have a decrease in the Achilles reflex because remember, 1, 2, S1, S2, buckle my shoe, so you have a decrease in the Achilles reflex. If you remember those, that's pretty much straightforward. That's like how I remembered it. So L4 radiculopathy is going to be decrease in patellar reflex because 3, 4 kick the door. L5 is going to be difficulty in heel walking, so you have foot drop because it's the peroneal nerve is L5. And then S1 is going to be tibial nerve is affected, so you have difficulty in toe walking, but you also have a decrease in Achilles reflex because S1, S2, buckle my shoe. All right? That's how I remember it. It's very easy. The last thing that they would want you to know is that you will see a positive straight leg sign. So what does that mean? Is that a patient is going to be asked to raise their leg, and then they will have pain essentially elicited upon raising their leg straight, okay? Because that's going to cause essentially the bulging of the herniation of the disc a little bit more, and that's going to lead to more pain and paresthesias and weakness, all right? And it could cause a drop in the leg, all right? So that's your signs of lumbosacral radiculopathy. Just remember those. It's very straightforward and easy. Lastly is neurovascular pairing. I kind of touched on this a little bit, but remember these two things. At the midshaft of the humerus, you will have the radial nerve and the deep brachial artery. So whenever you have a midshaft of the humerus break, the radial nerve is going to be essentially affected, as well as the deep brachial artery potentially. And then the other one is the distal humerus at the cubital fossa. The median nerve is going to be affected there, which you know that, right? Because of our mnemonic ARM, arm. But the artery affected there is going to be the brachial artery. All right, so those are kind of the two most important, in my opinion, for neurovascular pairing. That's all for the miscellaneous portion of the ankle sprains, the radiculopathy, and neurovascular pairing.